So let's discuss one question in ophthalmology which came in INI CET 2020. So the question says like this, that which of the following statements were true for association of primary open angle glaucoma, and they're given 5 options, and the 4 answers which were given, the 4 options which were given had multiple choices. Neither of them had a single choice answer, so it was a combination like A and B, A, B, C, C, D, like that. So 2 or more than 2 are correct statements in this question. So let us go one by one. The first question is, the pathology at the level of trabecular meshwork is seen on gonioscopy. There are 2 parts of this statement. The pathology of POAG lies at the trabecular meshwork. That is absolutely correct. We have this open angle and closed angle spectrum. The pathology of open angle spectrum lies in the trabecular meshwork, which blocks the fluid, the aqueous, to go out. But it is not seen on gonioscopy. In gonioscopy, we can only see the structures but not see the pathology of the glaucoma. So this option does not seem to be a correct answer. Alright. The first degree relatives of primary open angle glaucoma patients have 1% risk of glaucoma. So if you know the risk factors of glaucoma per se, of course intraocular pressure and hypoperfusion are important. They are the pathogenesis. Age, old age, family history. So family history and these 2 genes, they are related for POAG. So again, of course there is a family history in glaucoma patients, but the first degree relative has a much higher risk of getting POAG, not 1%. So this is also incorrect. According to various studies, it is definitely more than 10% of getting glaucoma in the first degree relatives, or some articles also show 20%. The relative risk of getting first degree relative glaucoma is 2.2%. Okay, so that in percentage it turns out to be more than 10 to 20%. And actually the incidence also in the first degree relative is much more. So this statement also doesn't seem to be correct. On dilating the pupil, the IOP always rises in POAG. Okay, so this statement is also an incorrect statement. The reason, because if you have a closed angle, this applies for closed angles. So in closed angles, the iris and the cornea are close together. So if we artifactually dilate the pupil by either mydriatics or in dark room, what happens? The anterior chamber, the iris is plugged towards the trabecular meshwork, the angle further closes and the intraocular pressure rises. That is why it is said that before iridotomy, you don't dilate the pupil. Pupil dilatation is contraindicated in angle closure because it can lead to pupil block, and which can lead to acute congestive glaucoma. So this option also doesn't seem true for primary open angle glaucoma. Alright, the fourth one. The visual field defect can be there with a normal cup-disc ratio. Now this cup-disc ratio, you can see over here, this yellow portion is the cup from which the optic nerve passes. The red portion is the neural rim. Now neural rim is nothing but the fibers, the axons of the retinal nerve fiber axons, which are formed by ganglionic cells. And in glaucoma, the basic definition of glaucoma is nothing but ganglionic cell loss. So if there is a ganglionic cell loss, there will be RNFL loss, and artifactually the cup-disc ratio will increase. But I always say the cup-disc ratio is not important. The ganglionic cell loss, the RNFL loss, the rim loss is more important. So this, even if there is a normal cup-disc ratio, for example, you can see over here, even if there is a normal cup-disc ratio, this patient, you can see the arrow, there is a RNFL wedge defect. Maybe ganglionic cells might be lost over here. So if there is a ganglionic cell loss, there is nerve fiber axon loss, which leads to red portion neuroretinal rim loss. Yes, of course, that can lead to increased cup-disc ratio. Like you see over here, just consider it on the red portion decrease and the cup-disc ratio will definitely going to be increase. But if you see in some optic disc, even if there is a RNFL defect, here the cup-disc ratio is normal. So RNFL defect can lead to some changes, early changes in the visual field. And of course, the question also says can. Also, in some cases, like the discs are very small, like in hypermetropes, there also the cup disc ratio is not appreciated well. If the cup disc ratio is not appreciated well, then of course the patient can have some visual field defect which is not seen in the cup disc ratio. So this statement seems to be a correct statement in this question for POAG. Alright, if we don't consider the POAG, then of course the visual field defect can be normal in normal cup disc ratio. For example, if the patient have a non-glaucomatous optic disc changes, like a visual pathway defects, so those, or people have peripapillary atrophy or branch retinal vein occlusions, so those people have normal cup disc ratio, but still there is visual field defects. But even for POAG, the statement holds to be true. Increased risk of steroid-induced glaucoma in a first degree relative. Okay, so this statement has been taken from a journal in which the PGI people have given an article. So they have told, and it is true of course, that the patients of POAG have more prone for response to steroids. Means if you give POAG patients steroids, there are more chances of increase in the intraocular pressure. Also, they have told that siblings and the offsprings of POAG also have more chance of steroid responsiveness. So if they have more chance of steroid responsiveness, of course there is increased risk of steroid-induced glaucoma in the first degree relatives, offsprings of primary open-angle glaucoma. So this statement also seems to be a correct statement. So we have ultimately got two statements which are correct, this one and this one for the question. So we have to answer in relation with POAG, and we have to answer as it was told that neither of the options has a single answer, at least two were correct statements. So out of these recall options, we could just pin down to these two as the correct answer for the question. Alright, thank you for listening. Best wishes.